Hello and good evening, good day, wherever you may be. My name is Simon.
Oh, this is worse than Instagram Live.
Pleased to meet you. My name is Simon Tomes. I am Emma the Embryologist's husband. So this is exciting stuff, right? Our first one.
Yeah.
Yeah?
Oh, yeah.
Yeah.
It's a bit, it's quite clever, isn't it?
It's great. So I can see this is the first time we're using this tool, and we can see we've got 7 people joining us today. Thank you very much for joining us. If you want to post...
9.
Oh, 9, it keeps going up. Hey, good stuff. We'll hit double figures in a bit.
Sorry, this will get really serious in a minute, but any of you that know me know that this is just my edge way in.
But this is wonderful. So we have Kelly from Rochester in Kent. Hannah, we can hear you. Thank you very much. And Cheryl and Emma, hi from Lincolnshire. Well, hello from Teddington in Greater London. We are not in a clinic. We are not in a laboratory.
Not in scrubs.
Not in scrubs. We are in our lounge.
We are in our lounge.
Yeah. And just to say that my background, I am in tech and community. So I am not a medical person at all. This is all about Emma. My role here is to host today and to ensure that your questions can come in and that I can ask them to Emma and we can have a conversation to help out. You know, this is about education. And I guess, maybe just before we jump into the topic, Emma, like for those that might not know you, could you briefly give a summary of who you are and also why we're here? Like take a step back from this particular topic, but why you do what you do.
Okay, so I think most people will have a clue of who I am. I'm Emma. I am an embryologist with 20 years experience, currently working as the lab director of the Eve Well Fertility Clinic, which basically means I oversee both sites on the laboratory basis, look after all the embryologists. I have a team of about 15 on 2 sites. Why are we here? We are here because throughout our journey to parenthood and throughout my time in the last 20 years of doing this job, I think that it is time that the patients have an opportunity to know everything that they need to know to make informed decisions. I have spent many years in an incredibly large clinic, and it wasn't until I stepped away from that I realised that actually the face-to-face patient care made me realise that people really don't understand this, and that made me really sad. I don't want our children to grow up in a world where they don't have access to what they need to make informed decisions about their lives, whether that be from day to day. And I'm a fertility expert, so I figured that if I'm going to do this, I should do it. And if anyone's ever heard me speak before, I use the term stay in your lane quite a lot. So that's why we're here, because I think that the more I get into this, the more I realise that people really don't have you don't know what you don't know. So my idea is to be able to give you what you know so that you can make the right questions and conversations around what you need to know.
Absolutely. And Emma, so Emma lives and breathes this, right? And I'm here to advocate for her. Living with someone who's so passionate about the world of fertility and like just straight up cares so much to make the life of her patients and even, people that she's never met before through her Instagram account, Emma the Embryologist, if you're not following, just helping people out. Like, I think like your reason you're on this planet, I mean, there's loads of other reasons why you're on this planet, but that's certainly one of them. So yeah, it's a real privilege to kind of, Emma is so passionate about this, right? So it was really, hey, let's just go for it. Let's start doing webinars. Let's start doing a podcast. And this is essentially the first one, isn't it?
And we'd like to welcome you to our experiment because we didn't actually know if this was going to work.
Yeah.
So anyway, let's go.
Yeah, let's do it. So this is recorded. So if you do want to come back to it another time, please do. We'll put out links to it through Emma's Instagram account. Come back to it whenever. I think it'll stay up for as long as we say it can stay up for. Spread the word. Please share this with others who you feel will benefit from learning about the Vienna Consensus and what it means for selecting a clinic. yeah, it's an important topic, right? So should we dive in? So the way this is going to work, we get to a point where we will ask you to ask your questions, and you can do that in the comments. But before we do that, I was thinking, like, let's start super high level. So Emma, what is the Vienna Consensus and why does it matter?
So the Vienna Consensus was created in 2017 by, basically they shoved a load of us in a room at an ESHRE conference. I'd say us, I wasn't there.
So ESHRE, for the audience who doesn't know what
is
that
the
means.
European Society of Human Reproduction and Education and Embryology. I can never remember what that last E. I should know this, shouldn't I? Anyway, I think it's embryology. Anyway, it's a conference that happens. It's a very, very massive European conference that we all fight over going to, because it's actually an amazing conference. This year it's in Amsterdam. They put a load of people in a room and they basically said, right, enough's enough. You guys need to come up with standards. You need to come up with standards about laboratory practice. You need to have, and those standards have to be set from, you have to encompass all demographics, you have to encompass all the people, you have to encompass all different walks of fertility and everything. And obviously they are averages. Not everyone will fall in them. Some people will go lower, some people will go higher, but ultimately, the reason they set these standards was that so that we had what we call key performance indicators that we could then all work towards, and we set our own key performance indicators within those figures that if we fall below, we are legally bound to start raising an incident report with the HFEA. The HFEA uses the Vienna Consensus to monitor clinics.
And just to jump in there, HFEA, for those who are unfamiliar?
It's the Human Fertilization and Embryology Authority. I do know what that stands for.
Okay, and that is for our international listeners who, because we're based in the UK, that's the UK regulator.
Yeah, it's right? A bit like the FDA in America. It's a bit like, there's lots of different, but our regulator is the HFEA. It's an incredibly tight entity that gives clinics licenses and allows them to practice. We're also regularly inspected, and on one of those things that we're inspected on is key performance indicators that we have to set out as a clinic. And that all came from the Vienna Consensus. So the Vienna Consensus broke down every part of laboratory practice into things that you can as a clinic affect. How many eggs a patient gets. We can affect that because we've got to have certain stimulation protocols, and the skill of our doctors and the understanding of your own personal reproductive health is what affects that. So you have those standards, which comes from probably the medicine side of things. But once it gets to eggs collected, number mature, number fertilized, number usable, number frozen, number surviving, all of those things are essentially handled by the embryology team. And so the Vienna Consensus was developed so that all embryology teams had a standard to meet. But I find it astounding that, first of all, it's called the Vienna Consensus. And I guarantee half of the people who watch this won't have even heard of it until last week. And actually, it 100% correlates with your potential outcome of having a baby in a clinic. And so I personally, instead of, we'll probably get there with all the questions in a minute, hopefully, but I would like to see it regulated heavily. It is regulated to a certain extent, but my question, as always, is why is it not open freedom information? Why don't people know this? Why don't they know what... Anyway, let's carry on, because I could just talk all night.
No, that's cool. That's cool. So hopefully, folks, that's kind of a good introduction to it, and that makes sense. So this is your opportunity to get your questions in. We're going to try, Emma's going to try her very best to go for it. We have up until the end of the hour, so let's see how we get on. So if you're feeling brave and you've got some questions, like, just absolutely go for it on the comments. I'll bring the question up on screen, so that's there for reference, and then we get started. So please have a think if you've got a question for Emma related to the Vienna Consensus and kind of, why that is important in your choices when it comes to selecting a clinic. Please do go ahead.
Dun, dun, dun.
Yeah, I mean I could got some more questions to keep us going there, Em. But let's see if we get a few more in from the audience. I'm just going to check to see if anything's coming through. Not at this stage, but that's fine. Okay, well, let me ask a question then. So this is something that, so you keep banging on about live birth rates, and your view that they shouldn't be the only thing people focus on. So live birth rates, they shouldn't be the only thing that people focus on. Why is that so?
Because the only opportunity that you have of having a live birth rate in any clinic is if you have an embryo in the first instance. And when you walk into a clinic and ask a clinic what your live birth rates are, even if you give them an age group, which is great, like live birth rate is absolutely important. I'm not saying it's not important, it's part of the Vienna Consensus. But you have to get an embryo before you get the opportunity to have a live birth. So the questions we all should be asking really is, what are my chances of getting an embryo? And then if I get an embryo in your setting, how likely is that to lead to a live birth? You've got some questions now.
Yeah. You got more on that? Because we can.
No, because I think actually
the
questions that I can see coming in are quite linked to where I'm going to go.
This is wonderful. So Archana, thank you so much. Can you run through the funnel stats briefly again? Sorry, missed the beginning of this. No worries at all for missing the beginning. All good. So let's get that one up on screen.
So a lot of us. So if anyone's followed my Instagram, you'll know that I talk quite heavily about the funnel. So everyone everywhere going through any type of fertility treatment, whatever that looks like, even if you're trying to conceive naturally, there is essentially a natural funnel or a funnel. You have a group of eggs. So many of those eggs will fertilize. So many of those eggs will make competent embryos. So many of those embryos will be genetically viable. And at the end, you get your pool of usable embryos from each cycle of treatment. So you get 12 eggs. Depending on how narrow your funnel is, you could either end up with 1 or 2 blastocysts, which is the stage that embryos need to reach to make you pregnant, or you may be really lucky and end up with 6 or 7. Now, a lot of that is going to be governed by your own inherent demographic. Why are you sat in a clinic in the first place? What is your reason for being there? What is your age? What's the cause of infertility? And a lot of that governs how that funnel looks. But also a lot of it's governed by the Vienna Consensus, because if a laboratory is performing at what we talk about as a benchmark value, you're definitely going to be better off with the start of that funnel, knowing that regardless of your demographic, remember all clinics see all these demographics. So averages do mean something.
Yeah.
No one is absolutely going to fall into those averages, definitely, and there's always going to be outliers. But ultimately, if your starting point is a good benchmark clinic, then your funnel will hopefully not be as narrow as in a clinic that's underperforming or competent, as we say. Underperforming is probably a bit unreasonable. Competent values are very good, but it's important to understand that 12 eggs in one clinic might only lead to 8 mature eggs, and that's all going to be governed by how well you're looked after through your stimulation phase. 12 eggs in another clinic might mean you get 11 mature eggs because maybe you were better monitored in a different clinic. That essentially, your start of your funnel already is bigger. And then you've got culture conditions and lab and stuff like that. So
if I'm going into a clinic, what sort of questions should I ask that are related to the funnel? Like, do you say, what does your funnel look like, or is it like
this is really tricky, and I think that's what Cheryl's asked here. Is I think the next question you can probably put that on the screen.
Yeah,
so I
sure.
think that's really important, because I think this is where we are going to. This is where we struggle, because.
Oops. Let's get that.
If you were to ask this,
so Cheryl's question is, how should we use this to assess a clinic? Should we be asking clinics to tell us if they fail at any of their KPIs? Great question.
So yeah, actually, it is a really good question, and it's really hard because you will get this really cagey response. If you walked into my clinic and asked me this, I can give you everything, like literally on a page of everything I've got. We do them quarterly. Most clinics do them quarterly. And then we have to do them annually, regardless, and they have to be broken down into ICSI for IVF, fertilization, embryo development. All the things I've outlined on the Vienna Consensus, I have to do every quarter and I actually break it up into age, because I think what the Vienna Consensus misses quite a lot is an age reference. The only age reference they give you in the Vienna Consensus is to do with implantation rate, which I get that, because they don't talk too much about PGTA, but ultimately it has to be said that your funnel, as you get older, gets narrower. So I don't think it's 100% fair that every clinic is expected to eat a benchmark 60% blastocyst formation if the patient is 43, because they're not going to. That you will get a narrower funnel in the higher age groups. So I think the Vienna Consensus misses that. But ultimately, your answer is yes, the data should be there. Whether or not they will share it with you is I would, but I find it's a difficult question to ask, and I appreciate, but it is there. They have to have it because it's part of our code of practice. It's part of our legislation.
And just quickly for our audience, you mentioned the word PGTA. What does that mean?
PGTA is pre-implantation genetic testing for aneuploidies, which we can get onto if anyone wants to talk about that later. But that's just another tool that we use to iron out that bottom of that funnel to see how many of the embryos are usable. Definitely in women over 37, 38, we start to use that quite a lot more.
Got it. Great. Hopefully, Cheryl, that helps answer your question for now. But yeah, keep them coming. If there's more questions off the back of what Emma's sharing, keep them coming. Okay, so we have Jennifer J. Thank you, Jennifer. Will all fertility clinics have this data available? I guess.
Yeah, they must have. They must have. And the problem is they absolutely must have. We have so imagine so my live birth data, for example, I've got everything up to mid 23 because you're still waiting for babies to be born in the latter part of 23. But I've got all my clinical birth data, which is heartbeats from embryos transferred right up to March of this year. So that sort of data is something we're monitoring. I'm doing it weekly or every other week. That's part of my role as a director of 2 clinics. I have to keep an eye on all of this. But every quarter we will do fertilization rates and stuff like that. And I think it's really important to, we have it. So like I said, but whether or not they'll share it is another matter.
So there's no what is it, sort of the GDPR kind of data requests where people can actually say, no, you have this information. But I guess it's not the patient's information. It's just information you've collected through your treatment. So a data request, they can't make a data request because it's not on there.
So what's really interesting is about all of this, the HFEA have it all. Because every time we make an embryo, every time we collect an egg, every time we make an embryo, every time we transfer an embryo, a form goes off to the HFEA. It's called a treatment form. And they have all the information from every single clinic.
So why can't they release it?
Because they can't pull data together properly.
Okay.
I didn't say that.
Okay, that's an unofficial line from Emma. Maybe we can get onto the HFEA and data a little bit later. But that's a good one to dig into. Thank you, Jennifer, for your question. So comment from Hannah. Thank you. We've not heard of this until last week. We've been going through fertility treatment on off for 9 years. We have gathered so much information since following you. Thank you.
You're very welcome. And that makes me really sad. But thank you. And that's why, it's comments like that make me realise how needed this all is. You shouldn't be going through fertility treatment for 9 years without actually... someone that's been going through fertility treatment for 9 years can probably tell me how to do my job because it's, you've done it so much, you understand. But I think it's the real nuances of how that then equates into how many embryos anyone ends up with. And I think it's trying to change that mindset that we are not all created equal. The skill set is different. And I get it. Not everyone gets to choose a clinic. And I think that's really important that we do touch on that. I get it.
We debate this a lot.
It's not about that.
Yeah.
But you still have a right to know what your particular chances of conception are and what challenges you're going to face regardless. And I think that data should be readily available. Things like, maybe you should do, because I'm just going to keep talking otherwise.
Go for it. We've got another 40 minutes. We're all good.
So I think it's like, I'm not saying any of what I'm presenting to you is easy, but I do think it's relevant to understanding what goes on behind that lab door. And KPIs have the effect of changing people's outcomes, and there are always going to be dependent on, like, let's talk about NHS clinics. The NHS is chronically underfunded, and I feel desperately sad about that. But it does mean that their ability to monitor patients through stimulation is not as good as, say, someone like ours, where we've got a mixture of consultants and we've got access to more care and we've got access to the bigger and better incubators and all of that. So, and yes, it pisses me off that that's the way the NHS is, but that's the reality. So I think if you are in a place to choose your clinic and you're actually delving into that private fertility world, then you should know this. Yeah, absolutely. Yeah, just more transparency. And I think that, your whole point about education, it's just... Because you often talk about how overwhelming it is for your patients or potential patients. Yeah, it's horrible. And you go on Google and you get scared and you're like... Don't go on
don't
Google.
go on Google.
Please don't
Like-
go. That's why I do it. Please don't go on Google. There's a really awful grading chart on Google that I want ripped down, and I can't seem to get it taken down because it's so awful.
Oh, really?
Yeah,
Oh, okay.
it's so awful, and people keep quoting it, and it makes me so sad because it's not even an acceptable form of publication. But it is like if
Maybe
you type in embryo grading,
Yeah.
it's the first thing that comes up. Please don't.
Yeah.
Please don't.
Maybe we could do a post on that.
I've done
Like,
one before,
oh,
and
take
I
it.
will do
Yeah.
it again because
Yeah.
it's really bad. Anyway.
Say, do not trust this data. Well, I mean, it's that's the thing, right? If these things get attention and the search engines start surfacing them, then we've got to find a way to counter that by sending out information that's actually correct. Got it. Okay, so thank you for that, Hannah. So Adele Johnson, from what you said, does that mean that the results are not available to the public? Yeah.
Yes.
How could the public get access to this data? Okay, let's bring that up on screen.
Great question.
Thank you, Adele.
Great question. The answer is you can't. The HFEA are 5 years behind on their live birth and clinical pregnancy rate data. They are in a bit of a pickle, is a very polite way of putting it at the moment. What's happened, to give you some background, is in the last 5 or 6 years, they have changed their data submission platform to encompass all the different electronic medical record systems we are using. Now, when I started embryology, which was in ancient times,
And what year was it? You said?
2002.
2002.
We used to have to fill out for every single patient. Imagine the transcription errors if you can. Like imagine, just for a minute, they were these forms that came as triploid. We
What is
used to
triploid?
triploid,
As in
so
three
to carbon copies.
Carbon copy, yeah.
We used to have to fill out every single patient cycle on these like HFEA forms, and it would be name, patient number, how many eggs you collected, how many fertilized, how many embryos were
So
frozen.
manually handwritten.
Manually handwritten. And this is all about like, but basically you've got to track every embryo that we make, because then we've got to talk about how many fertilized embryos were discarded because they didn't grow, X, Y, and Z. We used to do that manually, and one carbon copy would go in the notes, one carbon copy would go in the archive, and one would go in a sealed recorded envelope that went to the HFEA.
So literally take all
So
this.
over the years, what's happened is finally clinics are starting using electronic medical records. We use Meditex. There's something called Ideas. There's something called Baby Sentry. There's another one called MB App, and all of this. And what's happened is, because we're all on different platforms, but we're all collating the same data, the HFEA have had to change their data submission platform. So what we should be able to do is put all your data into our electronic records, which is what we do under your name as your patient record. And then we should be able to press a button that says send, and it should go off to the HFEA, and they should be able to collate that data. Now, what we have to send them is, when you start treatment, we have to tell them that we have to tell them that you've registered with us as a clinic.
Oh, really? Okay,
And we have
that's
to
interesting.
upload all your what called CD forms, consent of disclosure. We then have to tell them that you've started treatment. We then have to tell them if that treatment went ahead with an egg collection or an IUI, if it's with donor sperm, for example. The reason I say that is IUI husband partner isn't licensed treatment, so we don't have, that's not reportable.
RUI, what does that
IUI,
stand
intrauterine insemination.
Okay.
It's only reportable if it's donor sperm,
Yeah.
because you're using a donor gamete. By the by, so you have to tell them when you've had treatment. You then have to tell them what that treatment happened. So how many eggs, how many were mature, how many fertilized, how many embryos, how many frozen, how many discarded. Did you biopsy them? Were they normal? All of that goes into the form, that goes off. And then if there is an embryo transfer, we then have to do what's called an early outcome form, which is positive negative test. And then if there's a clinical heartbeat, it then generates a treatment outcome form that we're then expected to fill in within 52 weeks to tell them whether a baby was born or not. Okay, does that make sense? So there are like 8 forms. So what's happening, we're all working on these different medical systems, and the HFEA are a government entity who are, again, chronically underfunded. I'm not blaming anyone in the HFEA by this, by the way. They're actually wonderful humans. But it's the practice that's just really badly managed. And what's happened is the data submission isn't going off as supposedly streamlined as it should. And from what I've been told, we are going to be nearly 6 years behind before you as patients get any published data. Now, I think the aim, from what I've heard, is to make all of this quite transparent. I think it's what we all want. We want you to know that, like, I actually would like things really, really highlighted about multiple birth rates in clinics, because some clinics are overinflating their stats by putting more embryos back, so they look like they're getting higher live birth rates, but when you actually click in the right place and see that 30% of those are multiples, you then need to question whether you want to be in a clinic that's ethically not practicing, in my mind, correctly.
So the risks of multiples we talk about
is massive.
Yeah.
So that's what I think is happening. That's what I know is happening to the data submission. But whether or not this will ever catch up in a place where we can answer your question, Adele, that says, will it be available to the public? I think that is aspirational at the moment. I really hope we get there, because they've got it all. They've got we have to tell them what happens to every single egg that is collected.
I wonder, it makes you think, like, how as the general public we can lobby this stuff, like, and I know, you know, you have respect for HFEA and they're understaffed, underfunded, like many institutions out there, but I wonder if, you know, through our local MPs or through another body, we could all lobby and just keep saying, come on, like, give us an update on.
We do that quite a lot.
Well, yeah, but of course clinics do, of course you do, but as the general public, you know, come at it from both sides and just kind of push to say, look, how, you know, what is the roadmap for your getting your data up to date, and just keep on asking, like, what is the roadmap? Give me at least some sort of idea.
Yeah, well, I've been told it's this year, but I also know that there's so many problems. I don't think it will be this year.
Yeah.
So, anyway.
Good question there, Adele. Thank you. Right, let's jump on to the next one. So, Kelly HP. Here we go. So if we had 18 follicles but only 7 eggs, what could the reason be? Would that be considered low by the standards set? 31-year-old.
So this is a KPI. So the KPI for this, which you're talking about, is part of the Vienna Consensus, is eggs collected from follicles seen of over a certain diameter. And I think, off the top of my head, it's 12 millimeters. So again, so you've got so many reasons that you are not getting eggs from follicles. Right, so this is what I said about close monitoring. So you've got 18 follicles there that will hopefully grow together in a pattern. But sorry, I'm just reading down because Simon's showing me you've said something as well. I'll lead on to that, that's fine. Yeah. So what the follicles can actually, if you're not closely monitored, or your body just doesn't do what, I mean, I'm not, like I said, this isn't me sat here saying no one's doing their job properly. That's not what I'm saying at all. There are reasons that if you do not have, I think you should have 4 or 5 scans during an IVF cycle. There are some clinics that will do 2 and don't even do any bloods. I think that is the scale where things can be quite detrimental.
What's the reason for that number? Why 4 to 5 scans?
So because you would have a baseline, you then have 1 at day 6, you have 1 at day 8, 10, 11, maybe even 1 at day 12. Anyone that's done stimulation here, I don't expect you to understand it, will understand that that's what I was watching your follicles and trying to tweak your drugs to make sure the group of 18 that Kelly's got are growing together. If you don't monitor carefully, what you end up with is pools of follicles, some up here, some down there, and these do not ever mature. So Kelly, what might have happened is you had a group of 7 or 8 good ones and they got those out, and then unfortunately the others were just not grown enough, or they couldn't access them. I don't know whether that's ever been discussed. If you can't access an ovary, that does happen. Again, this is something that should be discussed before you go to egg collection. I don't believe in empty follicle syndrome. There's not enough evidence for it. You're definitely going to have the odd 1 or 2 that doesn't have anything in it, but no. So my thought would be that they're just maybe the hormones that they were giving you didn't grow them together in the right diameter. But this is a KPI. So one of the KPIs we have is percentage of follicles collected and eggs retrieved. That is one of the first Vienna Consensus KPIs. And I think in a competent clinic it's 80%, and I know in ours it's over 90. I think it's 94. So yes, Kelly, I think it's low, but I think there's too many questions in my head as to why. However, what you've gone on to said is that 6 fertilised, which is an exceptionally good fertilisation rate. But they haven't worked, which I'm really sorry about. So it'll be interesting to know how many embryos you ended up with, because the grade of your best one looks fine. And if you've heard me talk before, it's all about day 5, day 6. Anyway, we won't go on to that.
What questions could Kelly ask their clinic at this stage?
Exactly that. Why did you only get 7 eggs from 18 follicles? I was straight up. Just be really, really, really frank. Get them to show you the images, or we use like a plot on a chart to show where the follicles are. What was your estrogen on the day that they triggered you? Was it, if you had 7 eggs, for me it would have been around 8,000. If it was higher than that, then there should have been more eggs there. All of these questions, ask them. Why did I only get 7 eggs? What is your understanding of that? If you did this again, what would you do differently?
Yeah.
So ask how many scans you had. Was it 2? Was it 3? Should there have been more? Challenge it. But not, I mean, this isn't about anyone doing, like, so this isn't about people saying, I'm telling you everyone's doing their job wrong. I'm not at all. We're working our hearts out to try and make this work. But you have a right to say, is that comparable to what I would have got somewhere else?
Yeah.
So.
And those are tough, I could imagine those are tough questions to ask, but everyone should have the right to ask them.
Yeah.
And the good clinics out there would be like, okay, yeah, well, let's show you the data. Mm-hmm. Let's show you the comparables. Yeah, that makes sense. Hopefully that helps, Kelly. So Adele, follow-up question. Thank you, Adele. Are there any KPIs set too low in your view? Oh, good question.
It's a great question.
That is a great question.
Oh, now you're going to get my Emma opinionated head out, which is always a little bit touchy and a bit in no filter. I think that the competent damage rate for ICSI is way too high. So damage rates are. Give me a minute.
All right, just asking.
Seriously, don't work with animals, children, or your husband. So when we do ICSI, a certain number of eggs, unfortunately, will not tolerate that procedure. Now, there's many, many reasons for that. The first one is bad stim. So bad stimulation protocols will give you poor quality eggs, which then link into the lab of what we can and can't do them with. And once we put a needle into them, they can degenerate and they can become damaged. Eggs within ICSI should, and if you look at some of my videos on my Instagram, it's actually incredibly straightforward after you've been doing it, obviously, for as many years as I have, but they should tolerate it. That it's not this massively, what everyone thinks is massively invasive procedure. It takes about 28 seconds. It's very quick, and they should tolerate it. They should have a membrane is bouncy enough to tolerate it. You are always going to get the odd patient that has just drastically poor quality eggs, okay? And they are a different demographic. You have to move them aside. But again, I go back to averages are averages because we're all seeing the same demographic of patient, right? So eggs that are damaged, for me, should be less than 5% in any setting. And if it's not, why not? Is it the stimulation that's causing the eggs to be poor? Is it the practitioner's skill, so the embryology skill, that's not trained enough to manage it? Yeah. Is there something wrong with the equipment in the lab? All of these little things can add up to eggs becoming damaged. And I think if you're running at a clinic with over 10% of damage, I don't think that's okay. Because that means every patient with 10 eggs is losing 1 or 2 just to damage.
You think that is
I think that's way too high. I think what Adele meant is there any of the KPIs that I don't think are fit for practice. Yeah. That one I would like to see tightened up.
And how do you get that tightened up?
Training for everyone.
For the clinics, of course, but if you went to the HVA and you said, look, we need to make a change, how do you lobby for a change to the Vienna Consensus?
So I'd have to go, it would just be one of those conversations.
So that was 2017,
yeah,
right?
So they're going to do it again.
When's the next update?
2025.
Okay. So what's that, 8 years?
Yeah, something like that.
8 years,
next
wow,
year.
okay. Why do you think it takes so long?
Because it's taken that long for us to get new standards of practice. So things like, we've obviously moved into the realm of what we talked about earlier, PGTA. We've now moved into the realm of time-lapse incubators. And I think because of the integration of artificial intelligence, I think we are going to have to all sit down and make some new competent benchmark values that encompass the new technologies that we're all using, which we didn't have 8 years ago.
So time-lapse wasn't around 8 years ago?
It was, but it wasn't used in the way it is now.
Yeah.
For embryo selection.
You speak highly of time-lapse all the time. You know.
So that one. What other ones do I think are set too low? So I actually think the implantation rate with cleavage stage embryos is quite low. I think 25% is. I think that's quite low. Again, I don't really like that stat because I don't think it gives you any wiggle room for age. But I think if you go for gold standard patients that are we always use gold standard patients as under 35, which is what the Vienna Consensus is leaning towards without telling us that. I think that's too low. But again, that's my opinion.
So the Vienna Consensus, I think you mentioned this earlier, it doesn't
adjust
age?
for age. It talks about gold standard patients, which is patients under 35. Yeah.
Okay. But we talk often about age and the impact that can have. So why is it just because they just wanted to start off with a consensus and go, right, let's see. Yeah. Okay. So and eventually the new version, you think, in 2025
will bring in ages.
Will bring in age.
It has to.
Yeah. Okay. That makes sense. All right. Hopefully that helps answer your question, Adele. Okay, next up. So we have John. Thank you very much, John. I'm helping a relative look into egg freezing.
How lovely of you.
Yeah, very cool. In terms of Vienna Consensus, what statistics should we be asking clinics to help compare how good a clinic is at not only freezing eggs, but how?
Oh, I love that question. And I love that you're doing that for someone. So the really important statistics for egg freezing is the one in the Vienna Consensus that is eggs retrieved from follicles. So are the eggs and the follicles mimicking the numbers that you're getting? So what you see on scan, are they, at the end of the day, egg freezing is all about getting as much out of a patient in one cycle so that you don't have to put people through multiple cycles to achieve the end outcome, which is enough eggs in storage to protect your reproductive future. Okay. So if one clinic can give you 15, 20 follicles and get all of those eggs and get them into the lab, and then they're all mature. In egg freezing, we can only freeze mature eggs. Immature eggs do not tolerate it. Maybe the mid-range ones do, but most of the time they don't. So we don't, generally as a rule in the UK, don't freeze immature eggs. So I would say your best stats for clinics is your relative needs to be asking what potential number of eggs are you going to get in my demographic with my, how does it look before with her hormones and her situation? And then what percentage of your eggs overall are coming through as being mature? Now that again is a Vienna Consensus. And I think competent is, oh God, I should know this. Off the top of my head, I think it's 75%. Well, my maturity rate is 89. So it's massively broad. So if 7, like that's the difference between 15 eggs making 11 or 12 mature eggs and 15 eggs being 14 mature eggs, isn't it?
Yeah.
So, and then obviously the other question I'd be asking is most clinics now, I actually don't know of a clinic that's not doing this now, is vitrifying, which is the process that we use for freezing, vitrification. I'd also want to know how many of their own eggs that they have frozen are they thawing out. Remember that we do thaw out eggs a lot of the time that have come in from other clinics.
Yeah.
And it's not the thawing that very rarely has an impact on the outcome of the eggs. It's the freezing process they were done with. So freezing eggs at the moment is really hard because we're only just getting the data from eggs frozen 5 or 6 years ago, because it takes people 5 or 6 years to come back. So I actually think egg freezing is really good. And if I was to freeze and thaw eggs now at work in a trial run or a practice run with maybe some donated eggs that have been discarded, for example, I'm getting much better success rates now than we used to get 6 or 7 years ago because everything's really tight. But the only data we've got is from the people using it 5 or 6 years ago. But what you'd like to ask your clinic is how many of your own eggs have you thawed out? The ones that are frozen in your clinic, in your setting, because that's her statistic. I've frozen out loads of eggs that haven't come from my clinic, but that's not my statistic. That's the other clinic. Does that make sense? I hope that makes sense.
Yeah, it makes sense to me.
Then it must make sense.
It must make sense to the audience. Great question there, John. Thank you. Yeah, a nice one for doing that research for your relative. That's very cool. Okay, Archner, here we go. So question from Archner. Do clinics that are underperforming get closed down?
Yes. Oh, this is really hard because...
Why is it hard to answer this question?
Because the question of, I suppose it comes down to what we consider as underperforming and what the HFEA consider as underperforming.
So straight up question, do you know of any clinics that have shut down due to...
So the Homerton's closed at the moment.
And that's
to do with an incident in freezing embryos where a particular individual was not competency assessed and was performing the procedure wrong.
Oh, that's unfortunate.
It has affected it's incredibly sad.
That's unfortunate.
But because that again is, so that's not really a KPI. That's more to do with we have rules and regulations about how new staff are inducted and how we have to make sure everyone's working to our KPIs.
100%.
And that hadn't happened. So actually, by that not happening, they've broken the code of practice and they've been closed down because they are in breach.
Yep.
So I suppose that is underperforming, but the clinics that have been shut down, it's always unfortunately really, really serious when it happens, and it's probably too late, in my opinion, and it probably should have been picked up earlier. And I wonder whether that will come in the future with us all being had access to these stats.
Yeah, pick up on that stuff earlier. Absolutely.
So yes, the answer is there is definitely closures that have gone on. There's been a couple of London hospitals shut down over the years. There was one in Nottingham shut down in 2001 for can't remember now. But yes, if you look into so you can actually see, if you ever go on the HVA website, what they're really, really good at doing is actually showing you all the incidences that have gone on and what has been reported and what the changes are and stuff like that. And they do have, if they shut a clinic down, like Comerton, there will be a 70-page dossier about what's happened there and what the investigation was and what the next steps are and stuff. So they're actually really good at documenting all of that. Because ultimately they are a regulatory body, so they're very good at regulating, if that makes sense.
And having to take
so good at data presentation.
Well, yeah. So I guess it feels like the way you described that, like their primary goal is to take
safety.
action.
Their primary goal is your patient safety, and to make sure
which
that
will supersede anything
else,
related to data or analysis or analytics or any of that stuff.
So their main focus is always regulation and tightness and witnessing and us and our practices and stuff like that. So I get it.
So do you think there should be a separate body for the data analysis stuff and then them being on the safety thing?
So there is now, and that's where we're struggling, because there's this new data setup is a separate entity.
So it's not part of the HFEA, or
the
it's
HFEA
like
are So it's a partner of the HFEA. So it is. They are trying to set out the data, which is why I think it will come.
Well, then, that separation of concern could lead to them going a little bit faster, perhaps.
Yeah.
So.
Yeah.
What is that got a name, like that sort of?
Prism. It's called Prism.
Is that the project name or actual an actual entity?
No, that's our data submission platform.
Oh, okay. Curious. Okay, good question there. So we're going to bring up a question from Kelly H. Where can we view clinics' statistics?
So most clinics will have statistics on their website that you may have to scurry around to try and break down. I would be very wary about clinics that aren't publishing anything up to 2021, 2022. We've all got it. So I think that would always ring alarm bells with me if you've got a statistics and a really good entity with a website up with 2018 data on it. Where's the last 4 years gone?
Yeah.
But they should have them on their website. We are allowed. So it's a funny old thing, actually. We are allowed to publish statistics on our website, but we have to be adhering to the code of practice with how we publish that. So we can't publish anything outside of what would be considered HFEA data. So we are meant to publish under 38 and over 38, which I think is really cruel, because that means you're grouping a 38-year-old with the 44-year-old women, and their outcomes are completely different. But that's how the HFEA want us to present it. So you have to present it that way, and then you're allowed to break it down into different age groups.
But we break it down. You break it down, yeah. I know we talked about that before. But I'll be a skeptic here or play devil's advocate. Like, how can I trust the data that a clinic puts on their site? Like, is it, like you go on a website and they say all this?
No, they could get shut down.
Okay, so literally it will be checked.
They would be threatened with it being checked.
Yeah. Okay.
They could be shut down for that.
But can they manipulate the data, or some marketing person can go on it, and this is no disrespect to marketing people, but they could go, right, show this because it's great, don't show that because it's not so good. Maybe I'm a bit naughty asking that question, but I think
clinics can manipulate data because they can choose not to treat a poor demographic of patients. So one of the biggest questions I would always ask a clinic when you're going into them is if you know that you fall into a particularly poor demographic, like if you have a very low AMH.
AMH means?
AMH is anti-Müllerian hormone. It's a hormone that we all have tested before we have treatment. I would be asking them if they would treat you with that hormone level.
And if they say, no, we don't, then what do you say?
Then that is a reason to not go to that clinic.
Because they're trying to make sure they're more successful through selecting their patients. Is that what you're saying? Okay. Okay.
Yes.
I'm asking the direct questions here. Hopefully that helps you folks. I'm just going to do a quick time check. So let's just get that question off screen. Thank you, Kelly, for that question. So how are we doing? We've got about 15 minutes to get us to the hour, and we have We have a good number of stuff.
Ooh,
So
okay.
yeah, so at this point, we would just say thank you so much for all of these questions. This is amazing, right? And we do hope this is helpful. If we don't get to answer, or if Emma doesn't get to answer all of these questions, we'll try and spin up another webinar, and maybe we'll take these questions and then
I can post them.
and you can
Yeah,
post.
let me see if I can get to them.
Yeah. So Em, do you want to pick something? And I know this is hard having to pick.
No, I'm going to do a bit of we're going to do a bit of speed dating. Let's do it.
Go for it.
John,
Rapid fire.
rapid fire. How good is a clinic, and not only freezing, how usable then? Again, this is a really important question. So again, I can tell you from my own clinic how many eggs I've frozen that I've then gone on to use and thaw, and how they have performed in the funnel. So frozen eggs do not perform as well as any other embryo in a funnel. They tend to fall off a bit more. So you get eggs collected, eggs frozen, eggs surviving, eggs fertilized, and then you get the narrowing to the blastocysts that form.
Have you done that diagram?
No, not yet. Not with egg freezing, because it's really hard to do, because it's all age related and numbers of eggs. But
Okay.
I also have a full-time job and I don't have time.
That's
But John, it's a really good question, and you should be able to get that information as well. I could certainly provide it to you. I can tell you it's slightly lower, but actually our eggs tend to fall into our funnels quite nicely, like all patients, depending on when they were frozen. Okay, Cheryl.
Next one. Go.
So every clinic, if a clinic has a funnel average, then a funnel that NutriShare simply implies. No, I don't think it's. So that's really, really interesting what you say there. I don't think it's a lesser skilled embryology team. I think you need to put, like I always say, I think it has to be about context. So I think if you were underperforming in a clinic based on their own particular statistics, I think we'd need to look overall before we pulled any conclusions. There will always be people that do not create as many embryos as we're expecting them to. And actually, sometimes it can give us a really good indicator as to what else might be going on if that happens. I think instead of it being a blame thing, I think it needs to be an opportunity to look at the reasons why. I think if that's not done, then that would be my problem, is why are we not trying to look at what we can do to make this better?
Well, I always find it fascinating in Emma's industry that, you know loads of embryologists around the world, and in particular in the UK, and you're just helping each other out, even though you work for, put it bluntly, competitors. You're like, well, why would we not help each other out? And you do. You educate each other. You help other clinics by sharing advice and that. And I think that's amazing, right? It's not. You're not trying to blame. You're just trying to support.
No. I don't think it's about that. I think it's about you having the. Again, this is all about you just getting the information. Sorry, the above should say if they had a clinic that on average was worse than the funnel you shared. Yeah. So that there's your differences, and that's what we talk about all the time with Vienna Consensus in competent and benchmark clinics, is that you will get a difference in outcome because of that funnel. I have no idea what drives that funnel in other clinics. I know exactly what my funnel is, but obviously I'm only just highlighting it can be different.
So Adele's good follow-up question there from Adele.
Adele's.
Yeah.
Is there any getting stronger on interested in where you're focusing your efforts? Hope that's not commercially sensitive. I'll probably, although they can refuse on the grounds of the work in progress, an intent to publish. Are there any KPIs that I would love? I mean, honestly, my biggest thing and what we strive to do is our fertilization rate now is over 86%. So I'm pretty, and a lot of that comes from the key of the doctors and their performance as clinicians. I think they're incredible, and they're really, really bespoke and patient treatment. I would love to get to a position where we were getting 70% blastocyst formation. We sit at around 55, 60, which is still massive. That's still my big, what else? And this is what the world's working on. Why? And we know that a lot of embryos don't grow because of abnormalities in the embryo, and we can't fight that. But there's still embryos that I feel, why don't they grow? And is there anything that I could be doing in the environment to make that better?
And are your suppliers working on that?
Yeah. So there's new culture medias that come out all the time, and that's definitely a work in progress, because that's something that everyone gets frustrated with, is we do feel that there is definitely an edge. That I don't think there's many edges left in IVF. I think the highest functioning clinics are...
When you say edge, what do you
edges
mean?
As in gains, as in any more gains. I don't think...
Unless there's a completely new technology introduced, like ICSI when that came out, that was
massive.
groundbreaking.
Yeah, because everyone got fertilisation when they weren't. So...
Yeah.
Let me do. I had IVF, got 2 eggs. One was put back. I've been trying to decide to try again with eggs or double donor. I'm doing it solo mum. I'm thinking of going to try my own eggs once more. Any advice? Delia, I'm really sorry. That must be really, really hard. I would get a second opinion, check your hormones and your age and everything. And I think what someone needs to do is be really realistic about your chances with your own eggs if you go forward. And once you know those chances, you can make an informed decision. And that's all we can do. You can't overinflate it. It's mean to keep putting people through treatment for minimal percentage chances unless that's what you want to do. But I would want you to have a chat with someone and see if 2 eggs is your full potential, or if we could do better. This one is, what should I be thinking about deciding and how many embryos to stockpile before transfers just to 42? So if you're having genetic screening, we know that in our setting, a euploid embryo, which is a normally genetically tested embryo, gives you about a 58% chance, near a 60%, of having a baby. 70% of patients get pregnant with normal embryos, 60% around that take home a baby, a live birth. So given that, if you wanted to have 2 children, I always say to people to try and ascertain, aspirational sometimes, to get 4 normal embryos, to try and give yourself a really good chance of having 2 children. 5 would be thrilling, but at the age of 42, you're looking at about a 20% chance of each blastocyst being normal. So it really depends on what egg numbers are at the top of your funnel to whether that's even possible, and then you've got all the financial and emotional implications of that. So those would be the numbers, and I think that comes with a very big caveat that is not me belittling how emotional this journey is. It's very much about me being realistic about what the percentages mean.
Thank you for that question.
Adele has said, thank you for both giving up your Sunday evening. Oh, you're very welcome.
Anytime. Absolutely. I'll do more of this.
Last 38, 5 eggs before mature, 1 fertilised, transferred on day 2 straight after a collection. Has always been disappointed with the number of eggs, especially having a high AMH. So I'm pleased to see that you're starting very soon with us. I think if you've got a high AMH and you're getting 5 eggs, something's not going quite right there. That doesn't tally up. I'd be very interested to see if your antral follicle count is matching your AMH. That would be interesting. I'm not a clinician, so again, I'm going to stay in my lane. But I have been doing this long enough to know that doesn't marry up. I don't transfer embryos on day 2. I think to be honest, I think if they're in a really good culture incubator and environment, the only reason, I still don't really understand now why clinics transfer on day 2, because we are now bound by success rates, which are pregnancy rate per embryo transferred. So, and I think the idea was that we would only then be transferring viable embryos. You don't know the viability. You're literally 2 steps down the funnel. You're not at the bottom. You have no idea whether that embryo was going to go straight down and not make it, or whether it was going to end up being in that pool at the bottom that were viable. You've got no more information. And actually for you, Hannah, we now don't know why that embryo didn't work. Did it not grow? That's one thing. Or did it not implant? And those are 2 very separate things. So I think actually blastocyst culture, doing a transfer on day 2 is, without sounding crass, is to make clinics not have to give bad news.
Really?
Yeah.
Wow.
Because I don't see the reasons for it. Unless their culture conditions are suboptimal, I'm not worried about keeping my embryos in incubators until day 5, 6, 7. They're fine. So.
And okay.
Right, I think we're going to go with, I've had 2 rounds, 2 day 2 transfers due to 1 egg remaining both times. My clinic are pushing us not to culture the same situation. What's your thought on this? I think considering Pixie clinic, but they're saying lack of evidence. I don't have I haven't got a load of evidence on Pixie, unless you are, I think with all these add-ons, and I'm going to state it very clearly, I do think that all these add-ons are coming from a point of goodness. I think that they're being developed by people that genuinely believe they're going to help people.
Yeah.
But I think they work in a certain demographic, and if we start using them on everyone, we're never going to work out what that demographic is.
You talk
so
about this a
I
lot.
think people push these things on as we don't know what else to do. There is no evidence at the moment that Pixie does anything apart from a very, very small particular case of male infertility with HbA antigen loss, which is something that again, that's a very unique demographic. If your clinic are not pushing you to go to day 5, then they must feel not confident doing that. And I can't comment on that because that's not my culture setting. I feel very confident about patients going to day 5. All my patients with 1 embryo go to day 5.
Hope that helps, Emma C. Okay, next up, Sarah.
Is it possible to collect eggs in a different country and transport it to here? Yes, it is. It depends on which country. So again, this comes back to the HFEA Code of Practice regulation. We are again very, very tightly bound by what countries we can import and export to, and that is to do with the legalities of how we treat eggs and embryos in this country. If we cannot prove that the eggs coming in or the eggs going out will be treated in the same manner that they would have been under the HFEA Code of Practice, go with me, we are legally bound not to transfer. It seems mad because these are your eggs. I get it, but that's right. Especially coming in, if, for example, if the eggs weren't stored in what we call virology screened tanks, we then can't bring them in because they could cross-contaminate our tanks. I get that a little bit. The whole going out, I actually don't. I find that really hard. So if someone said to me, I want to take my embryos to the US for gender selection, I'm then not allowed to facilitate that because it's illegal in the UK. So all I would say is if you ever want to do take anything out and you, this is live now, just don't tell anyone. But yes, you can collect it. So there are very few, there are countries that we really struggle to work with, places in Africa, India, and it's all to do with their regulation. Europe's a fairly safe bet as long as they're not anonymous donation. The US is fine, Australia is fine. But any more than that, you do get into, it's definitely the African continents. India is a country is very difficult to import in from.
Okay, next up. Good question.
With time-lapse imaging, should your clinic be able to provide information about embryo development? If so, how would this be provided? Is there? So yeah, they should. So I'm a real big believer in. I'm a huge time-lapse advocate, and you'll know that from me. But I don't like sharing videos too much because I think they can become quite overwhelming for a patient to see. I think it's far nicer to do. I would actually like to do, if someone wants to break down their embryos, I'll do a Teams call and share my screen, and then I can go through the embryo's development. And if they can't provide you with that, they should be able to give you some sort of written report of what they have seen in that time lapse that is either normal or abnormal, and they should be able to break that down because we are watching them grow, so we know when they do certain time divisions and stuff. So I would push them on that. Equally, if you were then to go to another clinic and the clinic requested it, I can request time lapse from other clinics if I want to see them, and they should share them with us with your consent. Has to come with your consent, obviously.
And sorry, Kelly, you're getting ghosted there from your clinic. That's unfortunate.
John, how many eggs need to be banked to get one usable blastocyst? Now, I've got a really good spreadsheet on this that I've been a bit too scared to share.
How come?
Because it's horrible. Because it basically shows that a woman of 44 needs about 150 eggs to get one usable embryo, and it's hard to hear that. And I don't want to upset anyone. I don't want to. It depends. So, John, it's a great question, but it really depends on the age of the woman coming to this. So, if she was under 35, we normally say they need between 15 and 20 eggs. If she's between 35 and 37, we say 20-ish, 25. And if they're above 38, we start to get towards 25, 30 eggs. So before you'll end up with what we would consider the possibility of one normal embryo. I know that seems like a lot, and some women. I had one woman that had 12 eggs and ended up with 5 normal embryos. So it's subjective. Again, these are all numbers and funneling standards.
But to that point, I mean, we can go over time. It's fine if folks are good to go over by a few minutes. Just that around the sort of fear of putting out that data.
She's 39. Yeah, about 30 eggs, I would say. So, but it's quite hard to put that data out because again, it's my data, so it's not universal data, and I don't want to mislead anyone. So that seems something that I keep in the clinic.
Okay, so you wouldn't put that.
I don't think I'd put it on the Insta, no.
Because of it's like contextual to your clinic. Okay, I understand.
Sarah has written, is Iran one of those countries? Iran is one of those countries. I have definitely got stuff in. I've seen stuff coming from Iran. That's going to be really clinic dependent because it's to do with whether the clinic are working under the guidelines or not. We can look into it, but it's a tricky country. There you go. This is thank you both. Love touchy videos. Amazing.
Good stuff. And amazing. Thank you for your feedback. Thanks for that, Sarah, and Louise. I really appreciate that feedback. Wonderful. Well, folks, we've come to the end of the hour. Just gone over by a minute or so, but hopefully that's been okay. thanks so much for your time and for being part of this webinar. Very grateful for your questions, and yeah, stay connected with Emma as hopefully you will be. For those unfamiliar, Emma the Embryologist is your handle on Instagram.
Yep.
You post as and when you can. Emma, full-time job, family. We've got lots of stuff going on, so this is a real passion for Emma. I really want to reiterate that, as I shared at the start. It is about education. We have to do this. So let's keep it going. And I really appreciate that you were part of this with us.
Our experiment. That looks like it
worked.
worked.
Well, fingers crossed we can. Yeah, so we are hopeful that the recording has worked and it will still be available. So I think if you come back to the same link, you should get access to watch it again. But yeah, come back and watch it. We're going to do more. Spread the word. If there's anyone else out there who you feel would value following Emma and the information that she's sharing, then please do share that with others. And we'll do some more. We'll do probably a few more live, well, I say a few more, hopefully lots more live Q&As on very specific topics. So if you do have any other specific topic areas where you're like, I want to learn more about this, or I'm unsure about this,
just DM me.
Just send Emma a message. Absolutely. And we're also start this as a podcast where we don't take questions, but we use questions that you get all the time, and kind of repurpose some of the educational stuff that you put out, where you either do a video or you put some diagrams together. We'll have conversations about that stuff as well. So yeah, more to come. Thank you so much, folks. Do take care, and all the best. Bye for now.